So I was listening to or watching a video of Kelly Starrett, and he was going over hip flexion and how that implicates an athlete during their performance during a workout or competition, or just in everyday life. And the things that he was noting were hip flexion being limited by the hip capsule, and how our joint over time and usage can spin out of the capsule, actually get pulled out of the capsule in a way to allow us a greater degree of flexion, but at the cost of us losing some rotation in that hip capsule, because we should be able to approximate the hip capsule fully and fully rotate the hip 45 degrees internally and 40 to 45 degrees externally, and 40 to 45 degrees internally. That would be ideal, while the hip is all the way adjacent to the approximate to the acetabulum. But what happens oftentimes, athletes lose that from sitting, athletes and non-athletes alike, from sitting and environmental exposure and whatnot. But what we can do is we can determine whether or not we have a problem with the hip capsule versus a problem with the actual muscle length or myofascia, nerve mobility throughout the leg. And the way that we do that is through using something called the SFMA, and that stands for Selective Functional Movement Assessment. For those of you who have been under a rock, that's a way that we determine whether somebody has a stability or motor control problem versus a mobility problem, soft tissue extensibility, or joint mobility dysfunction. So I'm going to show you really quickly how we can do that in a supine position. Actually, I'll take you through real quick top tier assessment here. So let's keep those off. All right, so in standing, you should be able to. All right. So what we do is we have the athlete standing with feet together, and they come down and bring their fingertips to their toes, right? Knees stay fully extended. The weight should shift back slightly to account for my torso shifting forward, so that my center of mass stays roughly just anterior to the lateral malleolus and right in between my feet here. So when I come down, I want to come down one segment at a time, and then bring my fingertips to my toes, right? And what we're looking for is that posterior weight shift. We're looking for, do the knees stay extended, and also, do they have a uniform spinal curve, right? So if the athlete is able to get there, then there's no more testing that needs to be done, right? Because they're able to achieve the position that we want. But if the athlete cannot get there, say for example, they have a flat spot in their back, right? So they go down, great hamstring flexibility it appears, but their low back doesn't round at all. Okay, well that's a problem, so we have to break that out a little bit. Okay, so what we would do then is have the athlete sitting down, and then they're going to do the same thing. So it's the same position we're trying to get to, just all I've done is removed the ankle, knee, and or hip strategy. Okay, so I'm going to come down. What we're looking for, rounded, the back should be able to be rounded, and the knees should remain extended, and also we're looking for the sacral angle. We want to pay attention to that, make sure that they're getting some nutation out of the sacrum, or some of this flexion from the sacrum. And say for example we have the same athlete, the back wasn't moving when they were standing, but now we remove the knees, ankles, and hips, and they're still able to do this, but they have a flat back strategy still again. So I'm like, okay, well, it doesn't appear to be a hip problem in this case. It appears that the problem is from the hips and or above. So what we would do is we would try and get in the same shape, but we want to take the lumbar spine out of it, right? We're removing body parts every time. So what we do is we have the athlete lying their back, okay, and have them toes pointed up, knees fully extended, palms facing down, and then we want them to just slowly raise one leg up as high as they can without bending the knee, right? So we're looking for about 70, I like 80 degrees on that, without the knee bending, okay? Right side, same thing, right? So I'm able to get there. Obviously not a hamstring flexibility problem. If I couldn't get there, then we would want to take them there passively, have someone raise my leg for me while I'm relaxed fully, and if I can't get there then that means there's some sort of a mobility problem, right? Because I can't do it actively and they can't do it either, so when my muscles are turned off. So there's definitely a problem, something that's restricting that movement pattern, and that's where we get into this hip flexion that we're talking about and how to differentiate whether it's from something that goes beyond the hip or the knee, or something that remains proximal to this knee joint line, like some of that soft tissue or joint of the hip itself. So what we do is in that case we would go ahead and take them, get their hip, and see if we can pull that hip in a neutral position. We want to be able to get that hip up to the rib cage, right? So that's about 130 degrees, and that would be normal. You don't want to sense any resistance in the tissue. And what ideally I would do if I were testing someone, and I would approximate that hip, because we talked about earlier, remember that hip can spin out of the capsule and they can get a little bit more hip flexion range of motion, but that's not normal movement and that's not normal joint arthrokinematics. So what we're looking for is compression, slight compression, and then bringing the knee up to the chest while the opposite foot is facing up toward the ceiling. A lot of times people will be able to cheat on this test and they let that other foot just kind of spin out, but we don't want that, right? Because we want to see what's actually going on with the athlete. So mine looks pretty good. I get a little bit of resistance there. So in that case, we would say, okay, well, there's some sort of a, well, first, you want the athlete to try and do it themselves, right? So if they try and do it, and they can't get there, and then you try and do it, you can't get there, and then they've got some sort of joint mobility dysfunction or soft tissue extensibility dysfunction, right? So at that point, you would want to do some local biomechanical testing to determine, is this SIJ, is it the actual hip joint itself, or is it some of the soft tissue on the back side of the hip or the thigh that's kind of tangled up and fibrotic that needs a little bit of life breathed into it. You can use there's a ton of different mobility options to get that problem solved. But another thing I want to talk about was the athlete that I worked with yesterday. She's a gymnast, and now she's competing in CrossFit, and she was complaining about back pain. This is the first time I met her, and so I had her go through this top tier assessment for lumbar flexion, and she did have that problem, like I said, where she could bend down and touch her toes easily. However, she wasn't getting any movement out of her back. Actually, I take that back. She was getting some movement from lower lumbar region. Actually, it looked like a bit excessive to me, and but above that, it was all pretty flat. And I've seen this before in gymnasts having this problem. It's likely due to this ability to stabilize over time. They've been very rigid at that upper lumbar and lower thoracic region, and they've always had to be extremely flexible at the hip joint in order to do the things that they do, which are pretty amazing. However, it does cause that problem of non-uniformity of the superficial back line, and that's where we run into trouble, like spondy, for example. I believe this girl said she had a history of a spondy, so now she's got a fracture at L5S1 that she had happened when she was young. However, it may leave her susceptible to hypermobility at that segment. Okay, hypermobility at L5S1, hypermobility at the hip and hamstring area, and hypomobility or lack of movement
at the thoracic region and upper lumbar region. So what we would do then is take this athlete through more of a local assessment of the thoracic and upper lumbar areas to see if there's really a motor control problem or a soft tissue extensibility or joint mobility problem. So I hope that helps people understand a little bit more of what Kelly has been talking about in his video with Mark Bell on hip flexion and butt winking. That's how the conversation got started. You know, everybody's talking about it now. But so it can be a hip mobility problem, but it can also be a hip joint mobility problem, but it could also be a soft tissue extensibility problem, especially on that superficial back line or that lateral line that we went over yesterday. So make sure you check those things out. If you can't do it yourself, have somebody else check it out for you. Take a look at my hair. It's awesome.